I am Dr. Gowri Sankar, Professor of Orthodontics, Narayana Dental College, Nellore. I am author of the book titled Textbook of Orthodontics for Undergraduates. Today we are going to discuss about the permanent model analysis in orthodontics. So what is model analysis? Is nothing but analysis or looking at the models what we have got from the patient's impression. So it is done to see that all the three planes, that is the sagittal, the vertical and the transverse. Transverse is arch width and your sagittal is arch length and vertical is how much overlap between the maxillary and mandibular dentition is there. In order to assess whether the maxilla and mandible are correctly aligned to one another in all these three spaces, we do what is called as model analysis. This model analysis is done for qualitative purpose only. So the amount of crowding present, if not numerically mentioned, it is called as a qualitative analysis. If it is mentioned quantitatively, the exact term, the model analysis is applied. So it is a valuable diagnostic tool. It is an essential diagnostic tool. That means it is required for all the cases. You have to definitely take. So it is useful for assessment, it is useful for your diagnosis, and depending upon the results you got, you can plan your diagnosis. So it gives you the tooth size discrepancy, it gives the arch form and shape also, of course, but quantitative model analysis will take the arch size and alignment and occlusal relationship between the maxillary and mandibular arch. So remember the core concept that the model analysis is meant the concept of the three-dimensional relationship between the maxillary and mandibular in relation to the tooth size and arch length in the individual arches, as well as interdigitating the maxillary and mandibular arch. So by doing the model analysis, we know that if excess space are present or the discrepancy of the space is present, how to overcome this discrepancy or excess of space in the models or in the patient's mouth in turn, and to plan the diagnosis accordingly. So depending upon the stage of dentition, we know that our dentition goes through different stages: primary dentition, mixed dentition and permanent dentition. Accordingly, we have two types of analysis of model analysis. One is mixed dentition analysis, which is primarily done for prediction of the unerupted tooth that are going to erupt in the spaces where still some primary teeth exist. Whereas the model analysis is done when all the permanent teeth, that the permanent second molars have erupted already, and it is done to see that whether already erupted tooth are fitting into the given arch shape and form. We have accordingly some of these permanent analysis like Carey's arch perimeter analysis, we have Ashley-Howe's analysis, we have Pont's analysis, and we have Linder-Harth to say Korkhaus analysis, extension of it, and we have Peck and Peck analysis, of course the important one, Bolton analysis. Likewise in mixed dentition, we have the famous Moyer's analysis and Tanaka and Johnston analysis and Hickson and Woldfather and Hukaba analysis. These comes under mixed dentition analysis. But today we are going to restrict our discussion to the model analysis in permanent dentition. So model analysis, when we used to read, we used to do manually. Nowadays the things are changed, everything is automated. So if you just scan the models, they will give the measurements, including what to measure, how to measure, they do it themselves, and you will get readings directly read on the screen or displayed on the screen itself. But all these model analysis again depends upon certain principles which we should know definitely. So for requirements of model analysis, if you do manually, a well prepared model analysis without any bubbles or airspace anything, and a vernier calipers or a scale, at least measurement scale, and a divider, the divider available in our geometry boxes, and of course you have a brass wire or at least any ligature wire to measure the arch form or arch length. So as I discussed earlier, I am going to talk about one by one all these analysis which comes under our discussion now. The first one is the very easy one, the arch perimeter or the Carey's arch perimeter analysis. If I do in mandibular arch, it is named as caries arch perimeter analysis. The same thing when done in a maxillary arch, it doesn't carry any name. It is called as simply maxillary arch perimeter analysis. What is the purpose of doing this arch perimeter analysis? As the name indicates, I am going to now measure the arch perimeter and see that whether the tooth that has erupted is fitting exactly into the given arch perimeter without any crowding, or to say it forms a perfect arch shape. So how do we do this? So first thing is the calculation of the space available, arch perimeter available. It is done with the help of an brass wire. So this is how you can see the diagram. First you have to assume that the dentition is going to be a perfect shape without any proclination or retroclination. You start measuring the arch perimeter from the mesial marginal ridge of the permanent first molar of one side from left to right side. That means, in fact, you are measuring anything that is present mesial to the permanent first molars. Accordingly, you have to measure the total tooth material from one second premolar to the another second premolar. So I have two things now: the space available measured with your brass wire and the space required for the alignment of all the tooth which I have measured total tooth material. You have to now equalize both of them. Which is more? Is arch perimeter more, or the tooth material which is already presented is more? So the discrepancy or the amount of excess space now is calculated directly by arithmetic methods. And as I told that you have to assume that the arch is a perfect shape. Now what do you do when the teeth are proclined, your anterior teeth are proclined from canine to canine? You assume what is a perfect arch shape and try to predict how the arch form will be after your correction. That means when teeth are proclined, usually you have to measure your arch perimeter along the cingulum instead of the incisal tips what you measure normally. Now you have to measure on the cingulum when your teeth are proclined. Same thing, in class 2 due to the incisors will be retroclined, you have to bring them or procline them into perfect arch. Now you pass your brass wire in such a way that the brass wire passes labial to your retroclined teeth. So depending upon the amount of discrepancy or spacing, you decide what to do and dictate the treatment plan. Negative value indicates a discrepancy. That indicates tooth material is more than the arch perimeter. A positive value indicates that already arch perimeter is more, and the arch length discrepancy if it's 0 to 2.5 mm. This is old method, and it is modified by Profit again. In old method, when it is 0 to 2.5 millimeters, and you need not do anything, just like proximal stripping. Why all this is? To make the arch perfect. To method, now you have to assess what method of gaining space can I apply to make the intereditation between maxilla and mandible to a solution which is perfect occlusion. Now is 0 to 2.5 proximal method of gaining space has to be utilized, and if it is 2.5 to 5 millimeters, you can consider extraction of second premolar. Why second premolar means? Second premolar gives less proclination of your anterior teeth and more mesialization of your molars. This is another concept which is called as anchorage. If the patient's teeth are not much proclined and the discrepancy is 2.5 to 5 millimeters, you can go for extraction of premolars. And if more than 5 millimeters of space required or discrepancy is there, and if the teeth proclination is more, you have to consider extraction of the first permanent premolar, which is done commonly in orthodontics. This is old method. Now Profit has little bit changed it. So it is plus value, spacing required depending upon the overjet and overbite. You decide how to close this space. Now it is 0 to 0.1 millimeters. It is considered as normal alignment up to 1 millimeters. If 1 to 4 millimeters is there, mild crowding it is called. You can think about the non-extraction means of gaining the space. What are the non-extraction means? We have proximal stripping, we have distalization, we have expansion. And the problem comes if it is 4 to 7, depending upon the profile, it is called as moderate crowding. Either you think about non-extraction means or go for extraction of the second premolar. At the same thing, if the discrepancy is more than 7 millimeters, definitely consider it as a severe crowding and extractions are needed in these cases. So remember this is called as caries arch perimeter analysis. It is done in the lower arch. If the same thing is done in the maxillary arch, it doesn't carry any name. It is called as maxillary arch perimeter analysis. And next comes Ashley-Howe analysis. We have seen that caries as considered arch perimeter or anterior posterior arch length. But Ashley concept tells that the arch width should be in a proper proportion. It is nothing that when you construct a house, you construct pillars in the base. So the base should be broader enough to support the pillars. This is the concept of Ashley-Howe analysis. So he measures basal arch width. That means he is measuring the base. And he sees that pillars, here the pillars are called as the premolar dimension, PMD has called it. So these transverse diameters should match. That means the premolar diameter should not extend more than the basal support it is having. So according to him, if this arch width is not maintained, it leads to the crowding. So treatment planning should be considered now to expand the arch or not to expand the arch, if it is possible to expand the arch or not at the canine fossa region or the first premolar region. So what he does is determination of total tooth material. So from first permanent molar to the another molar, he called it as total tooth material. The 6 permanent teeth from first molar to molar, he called as total tooth material. Then he has measured premolar diameter from one buccal cusp tip of one side of first premolar to the another side. He named it as PMD, premolar diameter. This is equivalent to your pillars what I have discussed. Next, he has measured what is called as the PMBAW, premolar basal arch width. It is nothing but your canine fossa, which is a depression present in the distal to your canine or mesial to your first permanent premolar. If you are not able to find out this fossa, usually you have to mark the deepest fossa of the canine fossa. If you are not able to find this fossa, sometimes you can measure 8 millimeters from the gingival margin and can point it as a PMBAW on one side and PMBAW on another side. Now measure the width of PMBAW from one side to another. This is nothing but the diameter of the base. Now you have measured the premolar diameter, the diameter between the pillars. The pillar should not extend beyond the base. This is a simple principle when you construct your house also. Same thing, you see now that PMD is more or PMBAW is more. If your base is already more, PMBAW is greater than PMD, yes, you can expand the pillars. You can make the pillars move little bit away from the midline. But already your premolar diameter is greater than your base. You cannot further expand at premolar region. Expansion is not possible. You should think other methods of gaining the space. Now, okay, these are inferences. Now, second inference he has given is he has calculated the ratio of total tooth material. You remember that first step we have calculated TTM by PMBAW ratio. So, according to him, the basal arch width ratio maintains a proper ratio with the total tooth material. If this ratio is less than 37 degrees, it indicates there is excess of tooth material for a given arch width at premolar region. Then think about extraction. When same thing, if the ratio is 37 to 44%, it is called as a borderline case. Either you think about extraction or non-extraction depending upon the profile of the patient or proclination of the teeth. If the ratio is greater than 44%, definitely extraction is not indicated, and you have to think about non-extraction means of treating the case. This is your what is called as Ashley-Howe's analysis. Now we see the differences between the arch perimeter analysis or caries arch perimeter analysis and Ashley-Howe's. As you seen, the focus in arch perimeter analysis is anterior-posterior direction arch perimeter, whereas in Ashley-Howe's it is arch width discrepancy, and measurement you do the arch perimeter with the help of a brass wire, whereas you can measure here PMBAW and PMD with the help of a divider and a scale in case of Ashley-Howe's. And the arch, both upper and lower are used in arch perimeter and caries except for the name, whereas Ashley-Howe's is done only in the maxillary arch. And type of discrepancy, this arch perimeter analyzes the sagittal, that is how much of space present anterior posterior, to say that exactly anterior to the permanent first molar, whereas Ashley-Howe's concentrates on the transverse dimension, whether for the given transverse arch width the total tooth material fits or not. Now we proceed to the Pont's analysis. It is introduced by Pont in 1999. It considers the mesiodistal width of the permanent maxillary incisors. That means the central incisor, the lateral incisor on each side. According to him, for a given mesiodistal dimension of these incisors, there exists a ratio at premolar and molar region. If this ratio is not fulfilled, you have to expand or not to expand the arch. So accordingly, we have certain set of measurements. What are these measurements? First measurement is directly measure the mesiodistal dimensions of your incisors on the cast. This is called as sum of incisors or SI. Next, you measure directly on the cast from between the first premolars, the distal pit of premolars, first premolars, from one side to another. This you are measuring. So he called it as measured premolar width, or simply MPW. Likewise, measure the distance between the mesial pit of one first molar to the another first molar. This he called it as MMW, or simply measured molar width. Now you have got what is exactly present in your patient. Now you have to assess how much space ideally or how much arch width ideally should be for this case. So how do you do this? He has given a certain ratio. The ideal premolar width should be the sum of incisors into 100 by 80. Like that, for molar ideal width he has given same formula, except that the denominator is 64. So now you have a set of measurements, measured values. Now you have what is called as calculated values. Now try to compare. If the measured width is greater than the calculated width, it indicates that you have to expand the arch. If already your measured width is equal to your calculated width, think about other means of gaining the space. It's a normal arch. And if the measured width is greater than the calculated width, so no expansion is needed at all. Already your arch given has a broader width at given premolar and molar area. So what is the clinical significance of it? So it indicates where to expand the arch. So it looks similar to your Ashley-Howe's analysis, but remember, it doesn't take total tooth material into consideration. It takes only the mesiodistal width of your 4 permanent maxillary incisors. So how much is needed for a perfect alignment in a premolar and molar area? How much expansion is needed it gives. But there are certain drawbacks of it. The first one is there is population discrepancies or population variations. This is based on the French population. So next thing is, it doesn't talk about anything about the discrepancies of crowding in the arch. It only tells how much arch width should be. As we seen in our earlier 2 discussions, that we have to consider to make a perfect alignment whether the total tooth material is matching for a given width or arch perimeter. And as you know that it is measured only on the maxillary arch, it not considers the mandibular arch relationship, and the tooth may be malposed. Second thing is, you know that the maxillary lateral incisors are the commonly missing teeth, and we know that is what is the golden ratio. That means the width of the central incisor is 1.61 times that of the maxillary lateral incisor arch width. If this width is not maintained, the Pont's analysis is not valid. And of course, all the model analysis, they do not consider the skeletal relationship. Likewise, your Pont's analysis also. So now we go to Linder-Harth index. It is nothing but, if you closely observe, it is very similar to the Pont's index. So just like your Pont's index, he has measured premolar and molar, calculated as well as measured values. Only thing is a slight modification to the formula given by Pont's. You can see that the premolar width he has given the denominator 85 instead of 80, which is given in your Pont's index or Pont's analysis. Now Korkhaus analysis. Korkhaus analysis is called as a three-dimensional analysis. It is in fact an extension of your Pont's analysis to say Linder-Harth analysis perfectly. So Linder-Harth and Pont's are one and the same except for the denominator number of your premolar calculation. So why this is called as three dimensions? If you see that he not only measured the premolar or molar width, he has measured the anterior posterior dimensions, and he wants to predict at how much distance the incisor should be present from a given molar or from given premolar. Not only that, so now I have anterior posterior from incisors to intermolar width. As usual, it measures the first part, the intermolar or interpremolar width, which is the transverse dimension. He has measured the depth of the palate also. If you can see here, it is measured with a specific instrument called as Korkhaus meter. So he has measured the depth of the palate. So at the molar region, he has measured the width of the molars. From the intermolar line to the incisors, he has measured anterior posteriorly the arch in arch length, and second thing he has measured the depth also. Sorry, the third thing he has measured the depth also. These three things are presented in the modern analysis of Korkhaus. The arch width component is derived from Linder-Harth. We have seen that how to calculate a predicted value or calculated value of intermolar and intermolar from Pont's and Linder-Harth. So depending upon the sum of incisors, he predicted how much should be the anterior posterior and depth of the palate. So this we cannot calculate, it is given in a tabulated form. If anterior posterior dimension is less, it indicates that the upper anteriors are not proclined properly. If the same thing is less, it indicates an retroclined upper incisors. So the Korkhaus measures all these measurements, the perpendicular distance, intermolar distance and or interpremolar distance and intermolar distance apart from the palatal index. He called it as palatal index. This palatal depth should be 40% of the intermolar dimension. So you can see that Korkhaus meter, it is called as Korkhaus meter, and it is used to measure the three dimensions. This is one of the specific feature of Korkhaus analysis. He has measured certain predetermined values, ratios depending upon that. He has given a beautiful table. So if you measure the incisors, you can automatically see whether the anterior posterior dimension and the intermolar width as well as the palatal depth are given set matches with your patient. So the last one and very important one of our discussion is Bolton's analysis. So far, if you observe, we have seen all the analysis measured either the maxillary arch or mandibular arch. One specific feature of Bolton's analysis is it measures intermaxillary relation. That means the relationship between the maxilla and mandible it considers. Indirectly, it measures both the maxillary and mandibular arch. We know what is Andrew's 6 keys of occlusion. The molar relationship, the mesiobuccal cusp of the first molar occluding in the mesiobuccal groove, there should be proper proclination, there should be proper inclination, there should be no spacings, there should be no rotations, and there should be no curvosity. Of course, how is this possible? These 6 principles are only satisfied when there is proper ratio between the maxillary and mandibular dentition. This is called as your Bolton's tooth ratio. That is why it is called as the 7th key of occlusion. So it is proposed by Bolton. Again, it is based on populations. So there may be little bit of variations in different populations. So it is designed to see the discrepancy between the maxillary and mandibular arch. How do you do this? You measure the mesiodistal dimensions of 6 to 6, what you have done in Ashley-House analysis. Same thing, this gives you maxillary tooth material and mandibular tooth material. If you measure from 6 to 6, it becomes a total tooth material. If you measure from canine to canine, as the name indicates, it's anterior tooth material. So after measuring this, you have to calculate a ratio. He has given a ratio for anterior and posterior, simple. That is sum of mandibular 12 by sum of maxillary 12 into 100 gives you the overall tooth ratio. According to him, it is 91.3%. There may be slight variation because research indicates that it may extend from 90% to 92.5% depending upon the population where we are measuring. Same thing, anterior tooth ratio, he has measured from the canine to canine of mandible divided by canine to canine of maxillary arch. He called it as anterior tooth material ratio or anterior Bolton ratio. According to that, ideal value should be around 77.2%. So if this ratio is satisfied only, the arches will be perfect. So what happens if anterior tooth ratio is more or less? If greater than ideal, can you see here the numerator is mandibular arch and denominator is the maxillary arch. If the denominator increases, the ratio decreases, the value of the ratio decreases. Likewise, if the numerator or the mandibular tooth material increases, it will be more than 77.2% for anterior tooth, or it will be more than 91.3% for the total tooth material ratio. Depending upon that, if the ratio is more than ideal, there is lower anterior tooth material ratio if you measure the anterior tooth ratio, or if you measure the overall tooth ratio, the posterior segment will also be more. If the same thing, if the value I calculated for my models is less than the ideal, less than ideal means here 77.2, less than 77.2 for the anterior ratio and less than 91.3 for overall ratio. It indicates that the upper tooth material is excess since the maxillary calculations are done in denominator. So likewise, if overall tooth ratio is less than 91.3, the maxillary overall tooth material is excess. So what to interpret from this? If both anterior and overall tooth ratios are excess, it indicates that there is mismatch not only in the anterior region but also in the posterior region. You have to think about how to reduce the space, how to add the space in the anterior and posterior segments. Only anterior ratio is abnormal and the discrepancy is limited to your canine to canine region. So think about corrections involving in your anterior ratio. If only posterior is there, you can think about reducing the space in posterior segment. So there he gives a calculation what to do if greater than 91.3 or less than 91.3 for overall tooth ratio. Likewise, he gives for anterior tooth ratio how to predict how much millimeters by excess, not percentage. So it gives you how much millimeters percentage by excess by this formula. If the ratio is less than 91.3, it indicates maxillary tooth material, and the sum of maxillary 12 minus within brackets as given by sum of mandibular 12 into 100 by 91.3 gives you the amount of maxillary tooth material excess in millimeters, not percentage. Now you specifically know how much millimeters has to be reduced in maxillary and mandibular arch by doing these calculations. If anterior tooth ratio discrepancy is there, it is called as aesthetic zone. If small corrections are needed, less than 1 millimeter, you can explain to the patient. If overall ratio is more than 2.5 millimeters, you should think of adding any crowns or composites or by reducing by your proximal stripping. Why to reduce? Whether in the maxillary and mandibular arch. You know that safe reduction of any tooth material is 0.25 per side, that is 0.5 millimeters per each side you can consider. You have to correlate again this with your caries arch perimeter analysis. If it is less than 2.5 millimeters only, you can apply the Bolton's ratio, and composite buildups or the proximal stripping is considered depending upon where the discrepancy is there. So, what is the peculiar feature of Bolton's we have learned? It is an intermaxillary model analysis. It exactly gives where the discrepancy is, either in the maxillary arch or mandibular arch. It does not consider whether the teeth are proclined or retroclined. This is one of the disadvantage. Both upper and lower may be proclined, at the same time they can maintain a proper ratio. So, you have to see, in fact, not only this, all the model analysis in relation to your face profile of the patient. Next comes Peck and Peck index. So, according to Peck and Peck index, it is done in the mandibular lower anterior teeth. So, this is a name indicate that the mesiodistal dimensions of the lower incisors, they maintain a certain ratio with the labiolingual dimensions. If the mesiodistal dimension is increased in proportion to the labiolingual direction, you have to go for reduction of that space. So, he has given a certain ratio 10 and 11 millimeters he has given. How to predict it? If this ratio is not maintained, you have to do stripping. So, what are ideally model analysis used for stripping? One is your Peck and Peck index, but it tells about only in the mandibular arch, whereas a perfect comparison between maxillary and mandibular arch is given by your Bolton's analysis. These two are usually utilized for orthodontic purpose to see where the tooth material has to be reduced by proximal stripping. Remember, this is a non-extraction means of gaining the space. So, normal range of mandibular central incisor 80 to 92% of the mesiodistal width by labiolingual. Exactly, mandibular lateral is somewhat close, it is 90 to 95%. So, this is in essence all our model analysis. So, remember, what are all the model analysis that are done in maxillary arch? What are the model analysis that can be mandibular arch? What are the model analysis that can be done in both arch? What is the model analysis that compares the maxillary and mandibular arch? Now, we have Pont's index. It depends upon the mesiodistal dimension of your incisors. It gives you how much expansion is needed, and Korkhaus analysis is a 3-dimensional analysis. It is done in maxillary arch, and Linder-Harth analysis is nothing but equivalent to your Pont's analysis, and Ashley-Howe's analysis considers the arch width and it gives whether given total tooth material is perfectly fitting or not your arch width, and caries analysis is done in the lower arch. If the same is done in the upper arch, it is called as arch perimeter analysis. It gives you whether arch perimeter is fitting to your given tooth size or not, and the Bolton's analysis, which is called as intermaxillary, it gives you where the discrepancy is maxillary and mandibular arch. Not only that, within the maxillary and mandibular arch, where the discrepancy is there, whether it is anterior and posterior arch. And Peck and Peck index, it is based on the mandibular lower anterior teeth. It gives you how much tooth reduction can be done in the lower arch to maintain normal overjet and overbite. This is all about your permanent model analysis. Always there are some problems with model analysis. You cannot take it as individual analysis because they do not consider the facial and skeletal patterns which you have to analyze through cephalograms again, and it is limited to dental arch and arch measurements. As you do, it does not consider the skeletal and soft tissues. So, most of this nowadays we have population specific standards, but all the textbooks mention what the original authors has given to you. So, you should go through the population specific standards and apply whether the ratio matches with your patient or not. Sometimes you have seen that the abnormal tooth shape and size likewise in Pont's influences this analysis. Of course, all these are done manually. If it is automated, no problem. Manual measurement errors may occur, and it is measured at a single point of time. It is called a static evaluation. So it won't give you the dynamic changes that are occurring in the arch. Despite of that, still the model analysis remains an essential diagnostic aid in orthodontics. That's the end of this model analysis in orthodontics. Hope I made you understand some of the basic principles and made as palatable as possible to you. If you find informative, and this is very much applicable in day-to-day practical sessions also. If you have any doubts, you can contact me, and hope to see you in future discussions. Thanking you, all of you.